For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up. Season 3, Episode 27 of Surfing the NASH Tsunami, our review of the 5th Global NASH Congress, starts now.
This week on Surfing the NASH Tsunami.
Louise was there, and Rachel Zayas was there, and they did interviews.
The sisters were doing it for themselves at the conference, so we were doing really well.
So what Global NASH tries to do is to get grip on that number of patients that's just under the water currently because they are being taken care of by GPs.
I mean, I'm really excited to hear the readout from Madrigal Pharmaceuticals coming up. I know that many people are waiting on the next readout.
What we showed with that liver volume, resmetirom not only reduces liver fat, but it also reduces liver volume very significantly, over 20%. The liver volume reduction is not entirely explained by the liver fat reduction, and that liver volumes are greatly elevated at baseline, up to 50% in both non-cirrhotic and cirrhotic NASH.
During the conference, the concept of sarcopenic obesity was brought up. And what that means is that obese people actually have a deficiency of lean body mass, not just relative to their total weight, but just a deficiency in general for their ideal body weight.
Fat in the liver should not be there. It is an abnormality that is driving cardiovascular, diabetes, liver outcomes, and I think there is now this dialogue that's happening about how do we pull that pathway together where we can identify everybody at risk, not wait until one risk supersedes another.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader Professor Jarn Schottenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and our colleague, scientist, entrepreneur, and Age Diagnostics CEO Rachel Zayas, as they share highlights from the 5th Global NASH Congress, this week on Surfing the NASH Tsunami.
If you haven't noticed, this is going to be an unusual episode. Unusual in that I was planning not to go to the conference anyway, and then I turned up COVID positive, so I couldn't even if I'd wanted to. But Louise was there, and Rachel Zayas was there, and they did interviews. Rachel, unfortunately, couldn't stick around for this recording, but I recorded with her yesterday, and she and Louise recorded. And I have Louise with us today, and you and Louise, how are you today?
I'm very well, and the sisters were doing it for themselves at the conference, so we were doing really well.
The sisters did everybody tremendous credit, which is a good thing. As Jorn pointed out, hey, Jorn, how are you today?
Good. I'm good. Yeah, unfortunately, I couldn't attend in person either. I'm coming out of a long bridge weekend here in Germany, so I'm looking forward to your reports, Louise.
We've got a long weekend ahead with this Queen's Jubilee Platinum.
Yes, you do. It's already popping up all over social media. Very exciting. We had our Memorial Day weekend, which is it's a long week, not a celebratory weekend, or it shouldn't be a celebratory weekend. People have family picnics, but it's really to honor the dead of our wars. So
No, but I was watching a baseball game last night, trying to get into the St. Louis Cardinals.
St. Louis Cardinals.
Yeah, so I was watching it live.
An esteemed traditional baseball franchise. Good for you. And they wear red just like Liverpool.
They do.
And you are today. All right, so with that, just groundbreaker. One good thing, personal, professional, that's happened in the last week. Brave one, go first.
Let me start, Roger. Again, I had some time off clinics. I did a short stop in the hospital on Friday, but it was easy work. It's traditional on those bridge days that not too many people commute. So my commute was a lot faster than usual. If that could be every day, it'd be great. I think my highlight was, of course, the closing of the European soccer season. And normally I don't join you guys in being all excited about soccer games, but I think the Champions League final was an exceptional good one, and I enjoyed watching that game tremendously.
The less said about the result, the better. But we played well. We just didn't get the results. And well done to Real Madrid. That's all I can say. I suppose my highlight was actually getting to go to the conference in a local area for me, meet up with people and have some good conversations and some good presentations. So I enjoyed that.
So I guess I don't know, what's your personal best on a week that you're dealing with COVID? I guess my best is I have my voice back, or at least most of it, as you can hear. And my other best is my football story, which is that Antonio Conte appears to be coming back to Tottenham, and we've already signed 2 players, which is a record for Tottenham in the last decade. The idea that we signed anybody with more than a week to go before the end of the transfer window is fantastic. And the club is committed, between the UCL money and this, close to £250 million to bring in new talent, which means they're actually hopeful that they can become a solid Champions League team and maybe even compete with City or Liverpool if either of you winds up sleeping next year. Not that I think that's going to happen, but hope springs eternal. So with that, 5th Global NASH Congress. I guess about 35 speakers. This episode, you will hear portions of interviews that Louise and Rachel did with some of the various speakers. But Louise, before I do that, let me ask you to comment a little bit about what you thought was most intriguing about the conference, and of the interviews that you did and the speakers that you interviewed, who you thought brought the most interesting thing or perspective to the party.
No, I thought it was an interesting conference from multiple reasons. It's one of those conferences, because of its size, the sponsors get to present. And actually, that's really quite nice in some respect, because it's nice to know what they do and what they're about and why they got into the space and what they're bringing to the space. We don't get that at EASL or ARSLD or any of the bigger meetings. So there is a little bit more integration of industry, physicians and scientists, which is quite a nice mix. This year, they also had 2 patient representatives. They had Jeff McIntyre from GLI do a presentation, and they also had Marco Kroniuk, I think his name is, from the European Liver Patients Association, and he is always an entertaining speaker. He comes with such passion. When I attended it before lockdown and COVID pandemic, that was the one thing that I'd commented that was missing. I think last year it was also missing, and I made another comment on that. So it is nice to see it here this year, and I think people responded to it. They were both on the first day and they followed each other. So there was a nice sequence of events. I personally enjoyed Sven Frank's vascular alterations in NASH and NASH cirrhosis, and he'd alluded to some of this in a small amount of his presentation when he was in Barcelona at the recent meeting that Jeff Lazarus and Jean hosted, but he didn't expand. This one was probably more about the expansion of that into potential portal hypertension and how even small amounts of fat in the liver actually change the parenchyma and the sort of liver consistency in tissue. I've said before, and I think I've said when I was discussing it earlier, that I think that's something that we might be able to see in fasting, non-fasting differentials in FibroScan at an earlier date, at an early time point. Certainly in Barcelona, I had that discussion with Lawrence Sanderin, and he was of a similar thinking. Generally, the ability semaglutide data was presented. There was some interesting stuff on diet and the makeup of that. And Scott Harris from Altimmune I spoke to, and we'll be playing some of his input from that. He was very enlightening about the diet, and although we do know there's micro and macronutrient deficiencies, we haven't worked out are they particularly relevant, but was the sum up of that one. And on the Friday morning, there was William Alawazi, who unfortunately I wasn't able to catch up with to do an interview, but I hope to do something later. And his was emerging approaches to NASH and treatment strategies. He came with different aspects to the recent conference in Barcelona, but very much in line with sort of challenging some of the thinking that we're doing now, particularly, and Jean will have a view on this, on the placebo line of all of these trials, in the context that we still include people in the placebo line that are on medications that can affect their liver, pioglitazone, metoclopramide, metformin, all of those other ones that we know may well affect people's liver, and really should we be including those in clinical trials? And that was followed by a clinical trial roundtable where several Madrigal were there and some of the others, and that was an interesting debate, a panel discussion, because Scott Harris actually hosted it, and there was Sven, there was Paul Boods from Galactin, and Hamona Surek from doing that. And then Rebecca Taub was asked to comment from the floor, because of course Madrigal have had some very good resmetirom, so she was talking about it as well from that aspect. So it was a good roundtable discussion.
Louise, there's a number of things that resonate with me when you do the summary, and I agree with you that this particular conference is special because you have sometimes the chief medical officer of a company that runs the trial speaking up. Normally you don't get those. Either they have a presentation giving by one of their investigators or somebody else. So I agree. I think they being deeply involved with the trial and the definitions of endpoints and their own drugs, it's an interesting perspective. And I agree with you that Sven Franke is always a great person to reflect on the importance of comorbidities here. And if I understood you correctly, he picked up on the concept that we discussed podcast one or twice where we are starting to worry about liver disease in patients with NAFLD. The liver endpoints that are going to be relevant for drug approval are going to come up in advanced population, okay? So that's why we enrich those in clinical trials these days, F2 or even more so F3 if you think of the New England Journal paper, but that had only 4 years of follow-up, so if you follow those patients a little longer, you also see it in the F2s. And the ones that are earlier, they have serious medical conditions, and we got to take care of those. It's just not the liver physician that's probably the right person to do that, but the liver physician, as you rightfully pointed out, could be the one to identify the metabolic risk by using an ultrasound or a transient elastography device and counseling the patient. So I think that concept holds up through a number of discussions we've had now, and from a personal perspective, I think that's very important. It empowers the patient.
Yeah, and these vascular changes early in that NASH development, even before fibrosis is developed, are actually probably more important cardiovascularly, as you say, and in other related illnesses. But what he was very positive about is if you are able to alter the liver structure and get rid of the fat at that stage, it does come back to normal. So in those mild vascular changes, if you repair and remove the liver fat, the structure goes back to normal, which is really encouraging because we always talk about regeneration. And when does it lose its ability to regenerate? Some of the figures would suggest very late cirrhosis rather than late F3 and early F4, but we don't know. Maybe that's an area for further development and research, losing that elasticity completely.
There's one more thought I want to hook up on before, Roger, I'm handing it back to you, is that, the vascular bed in the liver is not a typical vascular bed as we see it with endothelial lining and the ones you have in the other vessels. It's a special one. And if any of our listeners is doing research in that field, please reach out to me, because I've always been fascinated by the fact that if you do an electron macroscopy section in the liver, you see fat bulbs or bubbles bulging into the stream of the sinusoidal blood flow along the hepatocytes. And I cannot other than think that this gives thrombocyte activation, release of cytokines right there, just from the mechanical differences a fat laden hepatocytes is causing in the liver. I think this is very fascinating, and it's not studied well. It might hook up to some concepts we're seeing, with hepatosmegaly or some things, but I'm convinced that this fat change of microvasculature in the liver has an effect for the patient.
That's really interesting, but not well studied, huh?
No, it's difficult to get hands-on blood cells directly in the liver. There are some studies that have tried to take portal vein blood, or let's say liver vein blood. You can do that through access through the jugular vein, for example. It's difficult then to study systemic changes and say what's happening in the liver. And it's not well studied. Some animal models have gone that way, but even there's not a lot of data. And I think there's lots of things we can learn about the liver vasculature and the endothelial lining there.
So one more way in which the liver stores its own secrets, huh?
Fully agree.
And I think what Sven was clear to propose was that the portal hypertension in fatty liver, which may be related to what Jean's talking about now, is different and may appear different to that that's developed in alcohol or in other causes of liver damage that cause portal hypertension. So there may be actually different types of portal hypertension being developed, which I've never really looked at. I deal with and treat people who have portal hypertension, but more from the physical side, the reassurance, the nursing side. Never looked at the schematics of how it could be different.
I wouldn't call it different types of portal hypertension, but I think the same pressure in a patient with NAFLD versus somebody else liver disease might impact the outcome a little different. So I think bottom line, what you're saying, if you measure actually HVPG as a surrogate of portal hypertension there, it's probably special.
So, Jorn, what would the difference look like?
There are some studies that are saying that even at lower pressures, you have more adverse outcomes in NASH, or you could say that the measurements you're taking are a little bit different compared to other etiologies when you look at outcomes. Again, addressing the variability you can have with HVPG between centers and standardization of the exam has some limitations to that, but overall there's a perception that, as Louise rightfully said, pressure you measure in NASH seems to be a little different in terms of compared to other liver diseases.
The next section of this episode will include segments of 2 interviews that Louise and Rachel conducted with the conference speakers, then my interview with Rachel, and then segments of 2 more interviews with speakers, and then finally our wrap-up.
This recording is an interview with Diederick Grobbe, who's the Chief Scientific Officer of Julius Clinical, and he's also a Professor of Clinical Epidemiology at the University Medical Centre Utrecht in the Netherlands. He's been a principal investigator in many epidemiological studies and clinical trials on the management and treatment of cardiovascular disease and the risk factors. He's also involved in several of the national and international cardiovascular guidelines. So I can't think of anybody better to discuss the getting a grip on NASH implementation of the International Clinical Screening Programme, and particularly the aspect of recruitment of patients and looking at how we implement clinical guidelines.
If you can introduce yourself for me and just tell me a little about what you do and what the GRIP program's all about.
As I said in the start of the meeting already, I'm not a NASH expert, but I've been working for decades in the cardiometabolic space, so it does rhyme. I've been trialing with new medication in diabetics and hypertensive patients and patients with acute coronary syndrome, and these are overlapping phenotypes, there's no doubt. So when NASH came on, I immediately became intrigued because it turned out to be somewhat of a separate pathophysiology, but not entirely, and clearly an emerging problem, increasing rates of obesity and diabetes and so on. If you look at what happens to these patients, their greatest risk is probably not hepatocellular carcinoma, but it's getting a stroke or a heart attack. We started building expertise, assembling our advisors around us, and increasingly felt that major improvements could be made in finding those patients by reaching further out in the community. So what GRIP on NASH tries to do is to get grip on that number of patients that's just under the water currently because they are being taken care of by GPs and not necessarily recognizing that there is more than their diabetes or there's more than their hypertension or their hyperlipidemia or their kidney disease, and just not aware of the nature and size of the problem. So bridging those two worlds by bringing centers of excellence with real expertise in contact with GPs surrounding them and trying to find new pathways of targeting the right patients. Underway learning about diagnostics and improvements thereof.
So can you just describe the format of GRIP? Because it appears to be based on guidelines and that interpretation of implementation,
yes.
which whilst guidelines are written, they're often not implemented.
No. And that's because routine care is not necessarily equipped to implement. In this case, it's different because we are designing a GRIP on NASH and supporting that also financially to follow the guidelines. Mm-hmm. The only thing we've done, as I've shown, is that we bypassed the step between FIB4 and FibroScan. We've simplified the guideline, the pathway, but we're also enforcing its implementation.
I think that's certainly somewhere that I've talked about on the podcast. If you find a liver at risk, you can do a blood test. If you find a blood test that's normal, you don't tend to find a liver at risk.
Yes.
And I think that's the opposite paradigm. And if you don't find the liver at risk, you don't find the cardiovascular problem, the diabetes. There are benefits to cutting out FIB4 en masse. And you can do the cost effectivity of that as to how much the FIB4...
Yes.
Everybody says it's free, but every blood test costs.
True.
Are you taking feedback from the GPs how they find it? Obviously, it's intrinsic that primary care take this on, as that's where most of the poor liver health is.
Yeah, that's true. So primary care physicians have been involved in the design. Mm-hmm. So it's not top-down specialist-driven, but they took part and take part in discussions, and we will monitor along the way what their experiences are.
Does this potentially mean that patients located with clinical trial inclusion criteria will be able to go straight from primary care potentially into clinical trials? Because at the moment, obviously, that isn't the case. They have to go through this whole rigmarole.
Yes.
So that opens up clinical trials like Donacry, GLI, ELPA talk about getting people with poor livers to clinical trials quicker.
Exactly. Currently, there's really, like, if you wish, an elite or a select group that reaches that. Yep. It's full of hurdles. So we need to take some of these out, realizing that the bulk of patients will be in the general population, unrecognized. So effective, affordable, credible tools to get to those patients directly is really going to help development of the drugs enormously.
And are you collecting patient-related outcomes?
Yes, we have the Liver Patient Association.
Mm-hmm. European Liver Patient Association.
Yes, that's it.
With Malco and that.
Yes, exactly. So they've endorsed this program. They will be our sparring partners. They also judge the protocols, and any material that we develop is going to pass their desk to have to input on it. And in the patients, we're going to collect prompts for just to see how patients value this.
I think you'll find a lot of people change their behaviour because they see their FibroScan or because they don't respond to blood tests.
No, but they don't know. And in fact, I'm from a different field. And for example, I've developed over the years different non-invasive imaging modalities for cardiac disease and vascular disease. And there too, people will not respond to a lipid value. No. But if they see a plaque in the carotid, it becomes a different story. So in that sense, imaging may help to motivate and make people compliant. We'll monitor that because, as shown, there's a couple of months in between the first and the second FibroScan in which they referred back to the GP for lifestyle measures. So we'll see what happens. That is not a randomized comparison with or without imaging, which would also be interesting, I believe, but it's a different question to ask.
So is one of the outcomes really to also enrich the knowledge in primary care of who they should be screening?
Yeah.
Because that means everybody gets screened.
Yes,
and
it's an important
without doing a direct.
Yeah, sure. So it's not really focused on patient awareness, but for sure on primary care awareness.
And the nurses are often the people who...
Yes, of
the
course.
diabetic nurse or the practice nurse.
So the practice nurses should be part of this whole scheme. There's also like educational programs envisioned for GPs and their practice staff to get them up and running for the screenings.
From my perspective, now more into liver wellness and that, I think it's exciting and I'm waiting to see the results, obviously several years down the line.
Yeah.
Because I think that's where poor liver health sits. Yes, there's a low-hanging fruit for NASH and NAFLD, so it would be really interesting to see what the diagnosis levels of NASH or just inflammation.
Yeah, so we'll see what dominates. It will clearly show what the real face of NASH in the real world is. At least I hope so. And it will also, therefore, potentially change the nature of intervention strategies because, again, I think that for the bulk of NASH patients, the biggest risk is not a decompensated liver eventually, but all that comes along with it.
You're putting FibroScan where I think, personally, FibroScan should be before specialist. It's an assessment of anybody who could have poor liver health. Yes. It's not a liver assessment for only liver patients because we all have a liver. I'm excited. I think the program, the way it's been designed, has got lots of benefits.
Yeah, thanks a lot. We feel too. So let's see what it brings us. We're certainly going to do it. We have enthusiasm from major centers in the countries that we listen, and the data will be generated. So.
And I think if it enriches the trial space with patients to go directly to the trials to get their biopsies, which are still required a lot sooner than it progresses. It's got lots of benefits.
Because it's a bit sobering that there's going to be potential interventions, be it old that I showed or new ones, but there's a shortage of patients to be studied. That is really impressive.
Thank you for your time.
Most welcome.
And good luck with the program.
Good afternoon. Thank you so much for being part of the Surfing the NASH Tsunami podcast. I would love if you could introduce yourself and I'll ask you some catered questions from there.
Hi, thanks very much. I'm Becky Taub. I'm the Chief Medical Officer and President of Research and Development, founder of Madrigal Pharmaceuticals, and involved with the development of resmetirom, which is a phase 3 thyroid hormone receptor beta agonist for the treatment of NASH.
Thank you so much. So I would love to hear about the resmetirom program and some of the data and insights that you've presented today.
Today, I presented an overview of data, some data from our completed secondary analyses of our completed phase 2 program, which actually completed a few years ago, and then talked about our phase 3 Maestro program, where we had one greater than 1,200 patient 52-week phase 3 trial, that Maestro NAFLD, that completed, and then ongoing serial liver biopsy trial, Maestro NASH, which is due to complete at the end of this year. So that's it in a nutshell, and we can talk about the specific aspects as you would like.
Excellent. What have been the biggest high-level insights in the last few months?
The areas that I focus on today was the data from our phase 2 clinical trial and from the cirrhosis arm and also the non-cirrhosis arm of our phase 3 Maestro NAFLD trial on the effect of resmetirom liver volume. So we know that from the phase 2 clinical trial that resmetirom potently reduces liver fat as measured by accurate and sensitive measure MRI-PDFF at week 12 and week 36 in that study, and also reduces and resolves NASH, and that patients with liver fat reduction on PDFF that's at least 30% reduced from baseline had a much higher rate of NASH resolution at week 36, including a reduction in all components of NASH as well as fibrosis. So we were very interested in what's happening in the liver in addition to just liver fat reduction. And we were able to use use the MRI PDFF images to measure liver volume, so serial liver volume. So look at liver volume at baseline that was calculated from the MRI PDFF by established methods, and then look at what happened to liver volume after treatment with resmetirom in both non-cirrhotic patients, which are the NASH phase 2 population, as well as cirrhotic patients, which is an open-label active treatment arm of Maestro-NAFL. So what we showed with that liver volume, which was the first part of the talk, was that resmetirom not only reduces liver fat, but it also reduces liver volume very significantly, over 20%, and that although in some aspect correlates with the fat reduction, the liver volume reduction is not entirely explained by the liver fat reduction, and that liver volumes are greatly elevated at baseline, up to 50% in both non-cirrhotic and cirrhotic NASH, and that resmetirom also reduces liver volume in cirrhotic NASH, and that particularly in that population, this is even more largely independent of liver fat reduction. So what is the liver volume reduction is a question. We didn't really get into the speculation, but as I was suggesting, it could be inflammatory milieu is greatly increased in NASH, and it could be inflammation that's reduced or other aspects of the NASH pathophysiology. The second part of the talk was to discuss the phase 3 program and some of the data that came out of our first phase 3 to complete, which was Maestro-NAFL, that we had completed near the end of January, and then the data from that study.
Excellent. I'm going to come back to some questions on liver volume that I have, but for the Maestro-NAFL D1 study, what diagnostic tools are you using for measurement?
What we've done is in all of our Maestro trials, we've used a series of non-invasive techniques to diagnose patients and then also to follow the treatment with resmetirom. We also are looking at how those baseline measurements are able to predict whether the patient has NASH on liver biopsy. So that's specific to Maestro-NASH, where we do have serial liver biopsies. So they're parallel trials, and so we'll have comparative data across a very large spectrum of NASH patients. Maestro-NAFL having earlier stage patients, where the average patient is kind of an F1, F2, and then Maestro-NASH having the later stage, F2, F3. We also, as I mentioned, have an arm that's a quite large arm of NASH cirrhosis patients, where we have the same sorts of measurements. We enroll our studies based on patients having metabolic syndrome or metabolic risk factors, which is very common in NASH. And what I showed was about 70% of hypertension, 70% of dyslipidemia, more than half are diabetic, and almost all of them, the average BMI is about 35, so they're almost all obese. So they have a high level of metabolic syndrome, which enriches for NASH, not only fatty liver, but it enriches for actual inflammation and fibrosis in the liver. And then we use a FibroScan, which is a commonly used office-based technique to further enrich the population in the Maestro trials, using cutoffs to then allow those patients to move to the next step, where they had an MRI PDFF, which measures liver fat, and at the same time, many of the patients had an MRE, which is MR elastography, which measures liver stiffness. And then we had a series of fibrosis biomarkers in the trial, as well as standard safety labs. So we have a lot of diagnostic tests being used in the study. And of course, we also, just to mention, we do have additional serum samples and plasma samples in case anything comes out of any of the ongoing research that we want to go back and look at.
Going back to a point you said previously in our discussion, this around liver volume, can you speak more about that? This seems to be a new and developing insight in the space.
Okay, so liver volume, there's been a few forays into trying to understand liver volume and measuring liver volume using MRI PDFF in the last several years, but really hadn't been applied to NASH therapeutics, which is interesting because it's logical,
yes,
to ask that question. We thought about it at the same time some other companies were thinking about it, and there was some literature, actually Rohit Lumba, who tends to be a bit ahead of the game, especially when it comes to imaging, had done a study showing this relationship of liver volume to PDFF, liver fat reduction, in a kind of a weight loss type scenario, and showed that it was quite a small change, so only about 5% or so. And we noted that some of the other analogs out there, like one class of GLPs, the volume reduction, even with a fairly robust PDFF reduction of greater than 30%, was around on the order of 7%, 10% with an FGF 21. And so we said, okay, well, we've got all this data. We need a serial PDFF study in phase 2. So we looked at resmetirom, and it was like a whopping effect of greater than 20% and extremely consistent with treatment, and not entirely related to the liver fat reduction. And also, I think the other important factor was that we didn't realize how enlarged these livers were. We knew that NASH livers were enlarged, but, if the average is 1,400 and they were upwards of 2,000, so they were very enlarged. And cirrhotic livers are enlarged. And there was some idea that, this enlarged liver was causing discomfort in these patients and pain in these patients. So maybe this was a way of improving patients, of reducing the liver volume would improve patients' pain scores, et cetera. So we were thinking along those lines, but this robust effect of resmetirom on liver volume suggested, well, are we reducing spleen volume, which is important in cirrhosis? So those studies are ongoing. The MRI could also be used. The spleen is on the MRI, so it can also be used to look at effects on potentially a portal hypertension-related endpoint, which is spleens get larger as portal hypertension develops. So what your question is just the way the field sort of moved, where people started looking at it, and we were one of the companies that looked at it.
Excellent. Now, during the conference, Dr. Scott Harris asked a compelling question, so I'm going to reiterate that question that he asked previously. Can change in liver volume compound the assessment of fibrosis?
That was a question at the end, and I didn't get to answer it as completely as we're actually doing. But the first thing to say that resmetirom in phase 2 had effects on to reduce fibrosis primarily in these patients with a PDFF response. So that they were responders to the drug. They had good drug levels. So they had significant liver volume reduction, and they also had fibrosis reduction, but primarily based on our AI technology in the more advanced F3 patients, where the F1, F2, which is a very, kind of early stage of fibrosis, there was less of an effect. And F3 has a very defined architecture. And so if you're disrupting bridging, it's much less likely that the contraction of the liver, the volume contraction, will impact the appearance. But with the early stages of fibrosis, where you're getting these just little strands of fibrosis, we reasoned that maybe it would actually make it look worse, or certainly resmetirom would have to reduce fibrosis more than 20% in order to be able to see an effect, a lot more than the placebo, which didn't have any liver volume reduction. So our two collaborators who are working on the AI technologies are looking at this factor, and one of them, we have a presentation at EASL, but does believe that you need to correct for the volume, and that the fibrosis benefit of resmetirom becomes more evident if you correct for the volume.
Excellent. Yeah. Thank you so much. We really appreciate your time and your insight.
Thank you.
And here's my interview with our good friend and collaborator, Rachel Zayas. First of all, thanks for attending for us, and thanks for doing the interviews that you did. I think the way this episode's going to shape up is that we're going to intersperse my conversation with you, my conversation with Louise and Jorn later, and the interviews. If you had to say, not from your perspective, but just from a general point of view, walking into the meeting, what you think the main story of the meeting was, what would you focus on?
I think it was predominantly industry. It was a lot of business to business, a few different imaging companies that were there. There was a little bit of academia and some patient advocacy, which I was really excited to see. So it was predominantly business, but a synthesis with academia and patient advocacy, which is really starting to get further into these conferences, which is nice. It's nice to see talks. It's nice to see data being supported in more than just a conversation. So it's starting to be actionable.
What about the patient advocacy elements of the meeting struck you most forcefully? Or was there data that anybody in particular put out that you thought was striking?
With patient advocacy, I think one thing that really stuck out was, as I had previously said with Helena Cortez Pinto during her talk, she was discussing about the best patient referral pathway. And I think that what we often forget as patients is that when you're bopped around from physician to physician, and it takes so much time to even get an initial diagnosis, these people are tired, they're confused, it's time away from work and family, and we often just want answers. It can be very frustrating to not know who to go to or what the next steps are. So I think with this talk, a few things that I took away was that risk stratification to really determine next steps, and if it's important to go into the specialist or be followed by a primary care physician for the time being. So scores using FIB4, ELF, and a FibroScan before getting into the secondary care clinic. I think that those things are important and being illuminated further. And I think that a lot of this will change, like the deficiencies and the delays in patient referral pathway to stratify, like who really needs to get into the next clinic.
You talked about the one paper from the woman in Israel whose name I'm forgetting right now.
Hermono Sarek from Israel. She was presenting on her study with transfer RNA fragments. The name of this paper was New Potential Therapeutic Targets for Relieving NAFLD-Related Steatosis. And what they found is in some human patient populations, transfer RNA molecules were found in these patients, were also found in mice that were fed a fat-induced diet, so obesity-induced mice, and they could use these as potential therapeutic agents. It's interesting because this is one of the first few times that I'm really hearing about gene editing, and I think that this is becoming more commonplace in oncology, but it's nice to see this upstream because I think that although the applications are different, the use of tools are similar in the sense where we find a target and we can either turn it off or silence that target through different mechanisms. I'm not sure what their specific mechanism would be for transfer RNA silencing, but this is becoming really commonplace in other places. Of course, like with another type of gene editing tool is CRISPR, and this is just starting to get used in a context that will have major implications. It's not yet used in the clinic, but studies are underway in many capacities, especially in the oncology space. So it's exciting to see this as a potential target. And what I really want to illuminate here is that just as we've seen with other more conventional therapeutics, which of course is out of my wheelhouse, but I'll speculate a little bit, these combination drug trials have been shown to be more effective. And I hypothesize it's going to be the same with these gene editing tools. So it's not one gene, one pathway, but it's multiple genes, multiple pathways that must be dysregulated or silenced in order to really have a positive or impactful therapeutic response. So I'm interested to see what transpires from this study. I'll definitely be watching to see. I will get in front of her at EASL as well. I really think it's going to be a combination approach.
Yeah, okay, I'll see if I can get it to you, because I think that's probably, we talked about that on a podcast about a month and a half ago with Scott Friedman and Neil Henderson. I think that's probably the most advanced of what you're seeing out there right now in terms of gene editing hypotheses, the idea that you can actually use mRNA to train CAR T cells to attack fibrogenic cells and destroy fibrogenic potential. Now, they've not done that in the liver yet with miRNA. They've demonstrated that CAR T can fight fibrogenic cells both in the coronary arteries and in the liver. But the miRNA thing, that only happened in cardiology. But nonetheless, I mean, that's pretty promising. And this seems like a simpler, would that be right? A variant of the same thing, also a gene editing application, but maybe something a little bit less complicated or complex to make happen. Am I reading you right?
Yeah, that sounds about right. Simpler is a complex term because simple in the sense where, yes, this might be one or several transfer RNAs that are targeted. The central dogma of biology is DNA makes RNA, makes proteins, and this is a form of RNA. And the complication here is that, well, it might be a single transfer RNA. There's various downstream proteins that could be dysregulated, silenced, or even upregulated, depending on the context of use of these tools. So there could be off-target effects works. It might not regulate the pathway as promising as we think. So there's a lot of complications in between. I think we're really just starting to understand how to regulate these. And that goes without even fully understanding the full context of this, because we talk a lot about liver disease, but we don't really talk that much about liver wellness and liver health. And it's the same thing with genes and proteins and transcripts. We talk a lot about how these entities or these oligonucleotides are dysregulated in disease, but what is the primary function in a healthy state? And that's what we really don't understand. So when we use gene editing, we need to really think about what other implications we're missing, because we are missing a lot. We're just scratching the surface. It's really just 1% of what's actually going on if we only see it in the context of this gene or this transcript is associated with this disease. So there's a lot to be known.
So I'm mindful of the idea that in most of the pharmacotherapies, particularly small molecule, the early stages were very, very blunt weapons. You hit a target and everything for 3 miles around it, and you then had to figure out how to manage all the collateral damage you were causing. I mean, most notably in early oncology, where the early oncolytic agents were toxic as heck, you only hope that they killed the bad stuff before they killed the good stuff, to oversimplify.
Yes.
But in other diseases as well, and what I hear you saying is this isn't that different.
Not at all. Exactly what you're alluding to. And I think the challenges, and this was actually what I focused on in my early career, is like, how do we get this gene editing tool into the correct tissue? Because if it's going to be injected systemically or intravenously, it needs to target the liver and not target another internal organ. Because if it gets uptaken into the wrong organ, it could dysregulate a critical pathway. So same problems here, but we're aware of that, and we're aware of off-target effects.
Any of the drug papers that you thought were particularly interesting, either because they lent insight to things that you know and work on right now, or because you just found them inherently important and worthwhile?
I mean, I'm really excited to hear the readouts from Madrigal Pharmaceuticals coming up. I know that many people are waiting on the next readout. So that predominantly, absolutely. And I think that was the main one for me.
Thank you so much for being able to attend. Tremendously appreciated. We're all glad you were there, and enjoy your week. For those who don't know, Rachel has changed her plan from she was going to work in Europe for a month to I can't work in Europe, so I'm just going to go to Morocco for 4 days and Paris for 2 and then come home. Have a great week, and we'll see you when you get back to the States.
Thank you. Thank you so much. Always an opportunity to be here.
Hi, we're here with Scott Harris, and we're going to be discussing some of his presentation today. So Scott, just go ahead and introduce yourself and just briefly summarise your slide presentation from earlier.
Oh, thank you, Louise. Well, it's a pleasure. I'm Scott Harris. I'm a gastroenterologist, hepatologist, and I'm the Chief Medical Officer of Altimmune. And we're developing a drug called pemvidutide for the treatment of obesity and NASH. And the essence of the presentation today was that the combination of GLP-1 and glucagon was synergistic. We've combined it in the same molecule. It's a dual receptor agonist, very similar in principle to tirzepatide, which within the same molecule combines GLP-1 and GIP. We think the advantages of glucagon is that it drives a different mechanism of weight loss. GLP-1 and GIP reduce appetite, whereas GLP-1 and glucagon reduce appetite but also stimulate resting energy expenditure. We use the paradigm of diet and exercise, and we have the potential for a greater weight loss better with that combination. We saw very promising results with semaglutide, which is now approved and marketed as Wegovy, with a 15% weight loss at 1 year, but there are counter-regulatory mechanisms that keep the weight loss from being any greater than about 15%. Even if you continue the drug for 2 years, there isn't any further weight loss, and it shows that the counter-regulatory mechanisms, as the decrease in resting energy expenditure works against the decrease in calories, and the patient achieves a steady state that's somewhat below the desired level. And the desired level is bariatric surgery weight loss, which is 25 to 30%. We're trying to achieve with medications weight loss of 25 to 30%. With tirzepatide, extremely promising results of 20%, and that data will be presented in upcoming meetings very shortly. We were able, with our drug in a first-in-human study, to achieve greater than 10% weight loss in just 12 weeks. That compares to tirzepatide achieving 20% at 72 weeks, so 1/2 the amount of weight loss, but in 1/6 the time. And if you look at the trajectory of the weight loss in individual patients, one does not have to have detectable liver fat by MRI to live a healthy lifestyle.
Do you have any data yet to suggest that when the drug is withdrawn, on in follow-up? Do they regain the weight? Do they do it at a different rate? Are they able to maintain an altered lifestyle that's been induced by the medication at all? Are there any?
We don't have that data from our study. We did not have a follow-up phase. This would have been ambitious for a phase 1 study. The data from the STEP program suggests that if you withdraw the drug, placebo patients who are on the withdrawal regain their weight, whereas those who are maintained on semaglutide continue to lose weight or at least maintain it. So these look to be chronic drugs.
Are there any micronutrient deficiencies or macronutrient deficiencies in losing weight that quickly?
Louise, it's an excellent question. As you know, micronutrients are tough to follow. You really can't assay them in blood levels, and sometimes you just have to see what a urinary excretion is in order to assess them. The general paradigm in weight loss is no more than 1% a week, and that's known from the bariatric surgery literature. So although the mechanism of weight loss with pemvidutide is a bit different because bariatric surgery is really restriction of intake, although it does stimulate the secretion of incretins because of the exclusion of the duodenal loop and the rush of food down to the ileum to stimulate GLP-1 secretion, there has been no micronutrient deficiency reported. Now, there have been a variety of things that have been reported with excessive weight loss, such as gallstones. And usually that's as you get to about greater than 1% per week. So I believe the answer to that question is no, but I think it should be examined more fully.
What would be the way to quantify micronutrients in this patient population?
I believe typically serum levels of micronutrients are unreliable. They don't reflect the body store of the micronutrients. So a typical way of assessing a micronutrient is a 24-hour urinary collection. Now, I don't know if that applies to all of the micronutrients and whether a serum level would suffice. So my answer for you is incomplete at this time. I think it's an important question. But if one looks at the bariatric surgery literature where they're exceeding 1% per week weight loss, and we achieved 10% over 12 weeks, so we were about, 0.83% per week. They haven't seen that kind of problem. But sometimes you see what you know, and if you know there's no deficiency, because you're set on there not being it, you don't see it. So I think we should look at it. During the conference, the concept of sarcopenic obesity was brought up. And what that means is that obese people actually have a deficiency of lean body mass, not just relative to their total weight, but just a deficiency in general for their ideal body weight. And what happens is because of the insulin resistance that they develop because of obesity, they don't have sufficient responsiveness of insulin in their muscle groups to maintain body mass. In other words, insulin is trophic, and it drives glucose into the muscle cell, and that maintains the muscle mass. And these subjects who get obese and insulin resistance actually have a scarcity of muscle and actually are sarcopenic.
When they broke down the STELLA-3 studies and split them out, when they looked at weight loss, there was a higher mortality in those who were cirrhotic who lost weight.
Right.
And that may well be that sarcopenic.
Possibly. I think in the NASH cirrhotic, the ones that are obese, we just don't have the data.
My name is Caleb Roberts, and I lead business development at Antaros Medical. And Antaros Medical is based in Sweden. We provide imaging services for drug development. So the types of imaging services include MRI and PET imaging.
How has the conference been for you so far?
It's been very good. I think we all like to be together again. That's one thing. It's good to meet people. So 2 things, actually, that I quite enjoyed. The very first talk of the meeting yesterday, Sven Frank gave a presentation about vascular alterations in NASH and NASH cirrhosis, and thought it was an excellent overview, excellent scientific overview as well. And I think increasingly now the drug development is focused on NASH and even in cirrhosis. He talks about many of the features of disease, which included ascites and portal flow, even splenomegaly and so on. And what I got out of that, being an imaging person and obviously working for Antaros Medical, we focus on imaging. There's a lot that imaging can offer and contribute in this particular area. And so imaging can quantify portal flow. We can even measure volume of ascites. He even mentioned about hypoxia, which I thought was very interesting as well. Certainly the other aspects like portal flow, measuring simple things like spleen volume, liver volume, even stiffness of the spleen and so on. In the setting of a cirrhosis trial, those quite simple MRI measures. In terms of the patient comes for a 15-minute MRI scan. We can do a variety of different measures, quantify liver fats, quantify liver volume, spleen volume, stiffness, portal flow, ascites volume. You can get a real amazing suite of imaging biomarkers that could really enrich the information for the clinical trial.
What have you heard that has been surprising or shocking, if there was anything?
Probably the discussion again around the regulatory endpoint, regulatory pathway. I guess it's not really a shocking revelation, but it's an ongoing topic of increasing concern. There's sort of a concern in the NASH community that, okay, drugs have kind of failed in the late phase. How do we avoid that? I think histology has been discussed quite a bit at this meeting, and I think that will continue to be the case. Certainly with AI, that could come in and help a lot there as well. So I think this is an ongoing theme through the year.
Yes. This has been prominent through many of the NASH conferences the last year and a half. It's interesting to see how regulators are communicating back and forth with the ecosystem. Do you think any specific modality of biomarkers or combination that will help with these clinical trial endpoints? Any thoughts there?
There are so many non-invasive tests in development. I mean, there's Litmus and there's Nimble that are evaluating all of these. Imaging, which is where I come from, there's so much that can be done. PDFF obviously is extremely validated by now. So I think as those continue to develop, as we continue to understand the nature of NASH in the context of liver, possibly and hopefully that there can be a combination. At Antaros, we've been working within the liver space for several years, especially within NASH. And of course, we specialize in PDFF, but also in MRE and some of the imaging techniques that I've mentioned already. What we've also done at Antaros for several years already is look at the holistic parts. And so not only measure the liver, but also with imaging we can measure what's going on in the kidney and also in the cardiovascular system. And I think that's a growing topic of interest. Let's look outside of the liver and let's see what our drugs are doing to renal flow, for example. And then, of course, there's an exciting area around the development of PET tracers, specifically for looking at collagen 1, for example, and also PDGFR beta.
Tell me more about looking at multiple organs. I think that this is the first time I've heard anybody say this, and it's been in conversation in the echoes between hepatologists and practitioners and other clinicians, where we cannot just look directly at the liver only and say we have had a good indication of where this patient is and what their long-term outcomes are.
From an imaging perspective, it's quite simple, really, because the patient attends for an MRI scan, and really we can image the liver in a very short period of time. We can then move to the kidneys and also to the cardiovascular system as well, and image the heart. So from an imaging point of view, then it's just about the analysis and about quantifying, as I say, renal flow, oxygenation, and then the various cardiac output measures that you can do with MRI. So MRI really is an amazing tool for quantifying physiological processes in multiple organs. Having said that as well, there's also the body composition aspect, so measuring subcutaneous fats, visceral adipose tissue as well. So you can get a really complex and comprehensive, let's say, picture of what's going on. Just going back to the discussion earlier today in the panel, actually, and it was interesting because I think there's a realization that there's a lot going on in the liver, and it's important to measure, and I'm talking about imaging again, but it's important to measure other factors in the liver. So if you're looking at PDFF, you must also look at the liver volume, because the liver volume changes over the course of therapy, and it's important to account for that change in liver, because that will have an impact on the relative change of liver fat. And there's many things going on, especially with the GLP-1 glucagon type of drugs, where it's important to also measure liver glycogen, to measure the water content. That's an important development that needs to find its way into especially early phase clinical development.
Before we finish up this episode, I want to take a second to discuss the conversations we'll be releasing this week. You might have noted we have more material than we're able to include in this episode. So the conversations will include the entire 20-minute discussion Louise, Jorn, and I held, the complete Rebecca Taub interview, expanded versions of the interviews with Drs. Harris and Grobbe, and my complete discussion with Rachel. So you'll get virtually everything that we've recorded from this meeting by the time we're done. With that, let's get back to the surfers wrapping it up. Okay, closing comments. We've now been to Barcelona. We've been here. We're going to Easel next month. What do you think is the most important territory for meetings to look to cover over the next year, somewhere at the intersection of what matters and what maybe hasn't been discussed enough?
To be fair, I think Jorn and Jeff brought it into their meeting. It's about this dialogue now between all of the areas and looking at NAFLD throughout the spectrum, not just NASH. Fat in the liver should not be there. It is an abnormality that is driving cardiovascular, diabetes, liver outcomes. And I think there is now this dialogue that's happening about how do we pull that pathway together where we can identify everybody at risk, not wait until one risk supersedes another. That's what I've been most interested to hear more about and see more content of in these meetings. Gradually, NASH Tag started it. There was the roundtable discussions. We had the EMA there this time for this meeting. We had the FDA, obviously, at NASH Tag. We are developing a rounded conversation. So I'd like to see EASL carry on with that. And having seen some of the program, I think that is certainly on the agenda.
Okay, Jorn?
Yeah. I think I agree with Louise. There's a number of flavors in the NASH conference fields. Some I like to attend as a clinician scientist. Some have really state-of-the-art translational scientists. I'm thinking back to Paris NASH, and we had Scott Friedman with us in the aftermath discussing some of the highly sophisticated technologies, single-cell genomics we're doing here. There were others that discussed drug development and the pathway with the regulators, like the NASH Tag, which I enjoyed. And there are physician associations, EASL and ASLD, that have their standalone meetings, of course, and drive the field in terms of people bringing in their abstracts and high-end science. But I'm glad you mentioned the innovations in NAFLD care again, Louise, but I think it's exceptional for that. It's trying to practically address the problems we're facing in the field. And as such, I do think, albeit having a number of meetings, many of them have their standalone justification and audience that will attend them.
I think you're on a land roughly where you did, which isn't so far from Louise. But to me, the two most interesting things right now are what are happening at the extremes. Extreme number one being basic science, and how much more can we learn about the basic science of this disease that will, I think, really drive us to think differently about cure over time, or if not cure, certainly permanent stasis. And then on the other hand, taking the urgency of the patient advocates and converting that into what can we do now, which I think is what Barcelona really did a superb job of dialing up more than any other meeting we've been to before. And you're right, Louise, you see more of that in the EASL agenda. You see more of that in everything. I think the patients are becoming more a part of the story, but nowhere as integral or central, I think, as they were yet, as they were in Barcelona. The large meetings serve a purpose because they bring everybody together and you can kind of figure out what's, I guess I'm going to call state of the art. No, leading edge maybe, but not leading edge, kind of up to date, okay? But the two areas that need the most work are the basic science and then delivering care to patients. And I think those, there are different meetings that are handling those, but my guess is over time, the ones that handle one of those or the other better are the ones that are going to have the greatest benefit, my belief. So with that, I'm going to give my voice a rest and let Louise go have dinner with her husband before he heads out to Taunton. Louise, thanks. Jorn, thanks. I'll be back with Business Report in a little while. And thanks, guys, for giving me shape to get my voice through this in one piece.
I was going to say, the voice is starting to croak now.
Yeah.
Get well, Roger.
Keep it safe.
And hang in there.
Well.
We're getting there. Thanks, folks. See you later. Bye-bye now.
And now for the Season 3, Episode 27 Business Report.
Hi there. I'm back with tremendous gratitude to Louise for filling in on this task last week, and to both her and Rachel for covering the 5th Global NASH Congress. As you can hear from the episode, I've worked to patch together several different interviews and discussions to make this week's episode click. I eagerly await your feedback on whether you like it, what we should keep for future use, and what we should never ever try again.
Roger's voice is back, but his COVID-induced brain fog put a dent in our schedule.
COVID hits everyone differently. I lost my voice and, more importantly, I spent most of the last week in a bit of a mental fog. For those who've been skeptical about reports of brain fog with COVID, I'm here to tell you it's real. As a result, two things I wanted to get done last week are still lagging: the cost metrics release and the voiceovers for the first diabetes special episode. In the interest of not missing another deadline, we're committing to post the diabetes podcast next Tuesday, June 7th, and to release the cost metrics by Thursday, June 9th. If I can get them done earlier, I will. Other than that, all is well. And we'll get on to next week's episode, which I'm pretty excited about.
Our weekly download totals are a bit lower than they've been recently.
All right, as I write this on Tuesday evening, we're a shade under 1,000 downloads for the past week. If we don't get up to 1,000, that'll be the first time in 13 weeks we failed to do so. That said, our 28 days over 500 download streak hits 7 weeks running, which is a record for us, and unless we're really dreadful, we'll hit 8 next week.
Still, the vault has a story worth telling.
Given that we had fewer downloads, the entire vault was lighter. The most interesting story the vault has to tell us this week is that there was an uptick in interest in Season 3, Episodes 4 through 6, and the Episode 4 conversations. In other words, all the follow-up from NASH Tag. Not sure why that is. If you're one of those who renewed your interest in NASH Tag episodes over the past week, please drop a note and let us know why. And with that, I'll stop while I can still talk. Deepest gratitude again to Louise and Rachel for covering the conference, to Mike for helping me patch these interviews into an episode and working late into Wednesday morning to get it done, and the rest of the crew, Eric, Steve, Murph, for keeping on and making things happen. In closing, I want to thank you folks, our listeners, once more. People say COVID leaves you tired for a while. That certainly has been the case with me, but your energetic support and feedback are providing the fuel for me to finish pulling this episode together before I go to sleep tonight or probably Wednesday morning. So stay safe, surf on. Look forward to seeing you next week on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.